services, detecting diseases, and instituting curative and rehabilitative measures. Protection of the health of the population is, however, not restricted to diagnosing and treating diseases. A large part of it has to do with ensuring that medicines and other health products that are intended to treat ailments and restore health are of high quality. This is where the LMHRA comes in. Ladies and gentlemen, listening audience, those that are online, I will give to you a few scenarios that you may or may not be familiar with. 2 years ago, a cough syrup was withdrawn from circulation in the Gambia following the death of 70 children. That cough syrup was contaminated with a toxin, ethanol glycol and diethanol glycol, that resulted in the death of the children that eventually had to be withdrawn. The World Health Organization routinely sends out alerts to countries about fake and substandard medication that countries will have to be on the watch out for. Many of us here may have gone to health facilities and have been diagnosed for maybe malaria or so, but you found out, despite the fact that you stuck to the treatment regimen, you took the treatment for the allocated number of days and times per day, you just cannot get well. You have to go back, what we call revisit. In recent times, the percentage of revisit versus initial diagnosis has gotten high. Close to 35% revisit for primary diagnosis where patients don't get well. How many of us here can say with certainty that the daily medication that we are taking for some chronic infection, disease, such or conditions such as high blood pressure or diabetes is the exact strength that we see on the package? We have a situation, an alarming situation that we need to address. How many of us don't know of some lady, and in many instances, gentlemen, that have had skin bleaching accident? The LMHRA has to deal with the quality, the safety, and efficacy of medicine and health products that come into the country. We want to provide a PowerPoint presentation from where the mandate of the LMHRA is, the gains that we have made in this short period of time, challenges, and where we want to take the authority in the future. The LMHRA was established by an act of legislature in just 2010. Its sole mandate is to ensure that only safe, efficacious, quality, high quality medicine and health products are in circulation in the country. And we do this by a number of means. Protecting the populace from the effect of harmful and substandard false medication, ensuring that there is fair practice in medicine and health products, promulgating regulations that will fight illegal trade, properly disposing of expired, illegal, and counterfeit medicines and health products, as well as facilitating necessary research and development, promoting pharmacovigilance, and disseminating timely drug information. Our definition of health product is wide-ranging. It isn't restricted to only tablet and capsule formulation. We work with herbal and homeopathic medicines, biological blood product, veterinary medicines, medical devices, narcotics, and cosmetics, as I mentioned earlier. We all are familiar with these noteworthy news items that occurred. 2020 LRA confiscating medicines and handing them over to the LMHRA. Below, you see a guest from the international community discussing with the president about the harmful effect of counterfeit, expired, and substandard medicines, and so forth. So what have we achieved over the past 5 months of our stewardship? LMHRA is no exception to situations that the current government met with respect to the internal harmony within agencies. We have managed as our first call of duty to de-escalate tension that have been in the entity, foster inclusiveness, and try to re-establish a work culture at the LMHRA. We have, in consultation with the Ministry of Health, migrated regulation for narcotics and psychotropic substances over to the LMHRA, where it will be better regulated. As we speak now, we are in the negotiation phase to start up construction on the leftover half-constructed laboratory that we have there. And we want to give special thanks to Honorable Julie Fatoma Weir, who has been instrumental in trying to lobby for support for the to start additional work for the laboratory. Sorry, wait. Great. So we have, just it. Okay, so what we did, the Honorable managed to acquire around $100,000 for the startup of the construction, and from the LMHRA's own internal resource, we match it with another $100,000, which we are now posed for issuing out a bid. We have reappointed a hearing board to begin to provide impartial reviews and recommendations for alleged violation. As we speak, an assessment is ongoing in Maryland County for the opening of Region 4 office in the Southeast. We are working with stakeholders, the Ministry of Health, USP, USAID, the WHO, and the Global Fund to ensure that the authority gains WHO maturity level 3, as well as accreditation for the laboratory. Negotiating with partners particularly the Global Fund through its implementing partner here in Liberia. We have gotten commitment for the provision of 2 Land Cruiser high tops, 17 motorcycles, as well as an incinerator. The LMHRA, again, through its internal savings, have purchased 2 vehicles for operational use. We have established, as I said earlier, a program planning and M&E office as well. Next slide. In the past 2 months, with support from the World Bank, we have completely dejunked and disposed of expired medications from 7 counties, as well as continuing the central medicine store. The 7 counties: Bong Niba, Lofa, Margibi, Riverset, Grand Bassa, and Montserrat County. We managed to pool and incinerate around 350 metric tons of expiry from those counties. As we speak now, we are dejunking the central medicine store. We have taken out 57 metric tons. Anyone going to the JFK Medical Center and the Redemption Hospital will know that expiries that have been at those facilities for the past 10 years are no more. Next slide. We're just showing you some of the services that we have provided just in a quarter 2. We issued out input permits as well as registering medicines. The numbers are there. Let's go to the next slide. Our lab is testing pre-market surveillance before commodities go into circulation. We send samples to the lab for testing. We also do post-market surveillance where those commodities in circulation in pharmacies and in health facilities, we go and do random spot check, take samples from there and send to the lab as part of our own way of continuing to protect the health of the Liberian people. Next. We did some product recall. There are products that are in circulation that were registered, and after further review, we thought that they were not safe, they were not efficacious, and we issued recall. You see 2 of those packages there on the screen. Next. Because we have to register and issue licenses for product, after testing, a number of commodities will be issued input clearances, but on testing, they are deemed unfit and we do not approve them. So you will see in this quarter, the period under review, we did not approve a number of products. Next. Okay, so we continue to have huge quantity of expired products. These ones that you see here are mainly from the southeast counties that we have not yet visited, but have intention of dejunking. Next. Some of the major contributor of expiry is the lack of adherence to donation regulation. Nowadays, and this may touch a sore spot with many persons, we have politicians, lawmakers, philanthropists, everyone going out of the country, and the first thing they do, they try to get donations to come and bring to the country, give it to their affiliates, constituents, and so forth to win brownie points. We have donation regulation. We appreciate if people will come and get those regulations from us as they go out aspiring and collecting donations. Like, street drug peddling is still a major issue. Next. Now we are on challenges. We just spoke of the street drug peddling, the inadequate space at the laboratory to perform the range of tests that we can safely say we are protecting the Liberian people based on evidence is still lacking given the inadequate laboratory space and also the fact that we do not have the quality and quantity of diagnostics instruments. Next. We are still combating controlled substances. These were confiscated at the Bowater side. These are consignment of tramadol that are trying to make their way into the streets. Another challenge. Next. One of the, and I will rest with these last two challenges. One of the major challenges to LMHRA not gaining is true relevance and getting the sort of support that it should require, given the important role that it plays, is the limited awareness and advocacy that the LMHRA has carried out. And we are hoping that such forums, such as this here, will begin to give us the sort of visibility and recognition. Next. For us, we feel this year is the biggest challenge, the budgetary constraint. The past budget year, LMHRA was allotted $1.4 million from the government covenants. Of this amount, 1.3 goes strictly towards salary and wages, with around 110,000 going towards the lease of the office. So we are left with just around 12,000 for goods and services. So this year is, I would think, the biggest bottleneck. But where do we want to take the LMHRA in the future? Next slide. If you look from the map on the left, the dots there represent the only physical presence of the LMHRA around the country, and mainly at border points doing inspection. The LMHRA wants to decentralize and be present in all counties, doing reverse logistics, pharmacovigilance, and basically assessing every commodities in county depots, pharmacies, and facilities. This is where we want to be going in the future. Next. Technology is everything. Our processes are largely manual and is fraught with delays and inconsistencies and error. We want to transform it digitally. We want to automate every process within the LMHRA. If you see there are 3 different processes that we are thinking on automating within the next 6 months. The laboratory information management system, the regulatory information system, and the track and trace, which is the bedrock for tracking and protecting commodities within the system. Next. We want to transition the huge consignment of pharmaceutical waste that we have been incinerating, burning. We want to transition from incineration to recycling, applying other methods of waste disposal. Next. as I earlier mentioned, we want to move the LMHRA from a quasi-political entity to a technical entity. With that, we have to regain our relevance in science and research. We will begin to organize scientific symposium. We will begin to build capacity in scientific writing. We will engage in research and build evidence base. Next. In order to perform adequately some of our functions, we have to appeal to the national government to complete the laboratory building that is standing dormant. We already mentioned that with advocacy from the honorable lawmaker, we got 100,000 that we matched with our internal savings, 200,000, but that is not going to complete the building. We will have to lobby for additional resources to get us where we want to go. Next. Thank you. Thank you for listening.
So guys, that was a question. Thank you.